only.
Good morning, everyone. Can you hear me? Am I audible, guys?
Message कर दिया.
Oh. Okay. 77 लोग तो ज्वाइन हो गए. Okay. We'll wait for a couple of more minutes and then we can start. We'll wait for a few more people to join. Okay, I think we can start. It's already 9:10, so I will just begin with introducing myself. If you guys have any queries or if I'm not audible or if there is any issue, please type in the chat box here so I can come to know about it. Okay. And I'm Dr. Satya and I'm a postdoctoral fellow in the Department of Radiology. So basically, I will be showing you few cases. It will not be a very long lecture. There will be few cases which will be relevant to you guys, which will be relevant to MBBS guys. So these are the things which will be usually asked to you in your MCQs when you are appearing for your PG entrance exam, and these are also relevant to you for your clinical practice in all your clinical subjects, orthopedics, medicine, or general surgery. So I have chosen just some simple cases which will be useful to you guys and which you can remember. Okay, so we will start with the first case. What we can do is I'll show the screen to you. The case will come up on the screen and you guys can type the answers. If I get 3 to 4 answers, I can go to the next slide and I'll show you. And then we can then discuss the case. Okay, so we will start with the first case. I hope I'm audible to everyone. Right, so I'll just tell you what this is. This is a plain X-ray of the abdomen. So basically the patient was in erect position and an X-ray of the abdomen was taken. And what has been shown to you on the screen is only a cropped image of the pathology of the disease. So can you guys see this? I'll just show you. This is the large bowel, okay? This is the descending colon here. This is the transverse colon. This is the ascending colon. So can you see any difference between the appearance of bowel in these various areas? Any guesses? Does anyone want to type the answer or anything? Like, I don't know any of you. Nobody is going to, evaluate you on the basis of this. So you can just type in your answers here. Anyone? Guys? IBD, okay. Anyone else? It's okay, just type in, guys. Think of something and type in. It's okay. We'll try to make it interactive. We will not be able to talk vocally, but then we can at least discuss here. Ischemic colitis, okay, good. Anyone else? All right, I'll move to the answer. So let us try to interpret what we are going to see here. So as I already told you, this is the descending colon. All right. What you see here, these lines. Basically, this study is a barium enema study. So what is done in barium enema study? A barium-based contrast is instilled through the patient's rectum into the patient's large bowel. So all these white things that you see here, this is all barium, and all the black things that you see is the air which is mixed with the barium, okay? So this is a double contrast barium enema study, okay? And the lines that you see here, these are all hostrations which will be normally present, okay? So in the descending colon, you see hostrations, In the ascending colon also you see these horstrations, but there is something definitely wrong with the transverse colon. So what is happening with the transverse colon? I can show you these. Can you see these bumps over here? There are these C-shaped bumps coming up over here, right? So this kind of appearance is known as the thumb printing appearance. It appears like this is the thumb of a person. And why this kind of appearance has come? Because there is congestion of the mucosa due to some reason. Most commonly, this is seen in ischemic colitis, as was answered by Aditya. Okay, good Aditya, this is a good answer. So ischemic colitis, commonly it gives rise to the thumb printing appearance. Why thumb printing appearance? Because there is absence of flow to the bowel, which leads to congestion of mucosa, and the congested mucosa will swell up and it will give rise to thumb-like appearance. Okay, so this is very classic thumb printing appearance, which is seen in ischemic colitis. So what leads to ischemic colitis? Like what will happen that will lead to ischemia of the bowel? Okay, we'll just see some of the causes. So ischemia can be either because there is compromise to the arterial flow, compromise to the venous flow, or it could be also because there are low flow states like hypotension. So when a patient is in hypotension, the pumping is not enough for the blood to reach there, right? So that is why the flow to the bowel is compromised in such cases. And other conditions such as sickle cell disease. Why sickle cell disease? Because there are those abnormal blood vessels, abnormal blood cells, which will go and they will clot the smaller vessels, and that will lead to ischemia. Okay, so this is clear. I hope it is very simple for everyone to understand. I'm trying to explain very simple things which once you see you will not forget. Okay, so you can use these things in your exams also. You can, you know, when you're writing your final exam, no, there may be things that you have read somewhere and you can just recall it anywhere. You can connect in it, you can write it in your exams. Okay, so ischemic colitis is clear to everyone. We'll move to the next slide. Again, this one is a plain radiograph of the pelvis. As you can see the pelvic bones, this is the sacroiliac joint here, this is the sacroiliac joint here, this is the sacrum, these are the iliac bones on both the sides. And you are seeing some, I'm sorry, okay, fine, I'll just explain it to you since we already got the slide. I'll just show you the findings here. These are multiple, can you see these are multiple calcified structures in the pelvis, which is very unusual it is very unusual to have something calcified in the pelvis. And if you look closely, you can see that these resemble something. Can anyone type in what does this resemble? Something else in the body which resembles very similar to this? Okay, does anyone think these look like teeth? Yes, good. They do look like teeth, right? So basically, this is a teratoma or a dermoid cyst, a mature dermoid cyst. Why do teeth appear in the dermoid cyst? Okay, we'll start with what basically is a dermoid cyst or a teratoma. So, teratoma is embryologically, no, teratoma is a tissue. Okay, it's just taking just a second, yeah. Teratoma is a tissue that will contain, you can just concentrate on this line, pluripotent stem cells that fail to migrate to other sites. So basically they will have pluripotent stem cells that can give rise to all the embryological layers. So the components of the endoderm, mesoderm, ectoderm, everything can be present inside the teratoma. All right, so since they are pluripotent stem cells, they have the potential to differentiate into any of the stem cells, any of the other tissues, but they will not migrate, they will not go to the sites where they are supposed to go. They will just stay there in the pelvis. Therefore, a teratoma is a tissue which will have multiple types of tissues inside it. What you have to remember is the most common type of tissue which is found inside teratoma is fat. In fact, when radiologists are looking at a tumor and when there is fat content, the suspicion of it being teratoma goes very, very high. So what you have to remember is that fat is a very important component of a teratoma. Okay. Other than fat, you can focus on the last point here, calcifications, including teeth, which you saw here. It is not necessary that you see teeth in each and every case, but some form of calcification may be present. Not always, but may be present. What thing which will be present almost in all the cases is fat. So what you have to remember is that teratoma will have multiple types of tissues in which fat will be a predominant tissue, or fat will be a tissue which will be present in most of the cases. All right? It's clear to everyone, right? Okay, it's very difficult to not get your feedback and then go on. So one or two can just type in yes, or you can just put a thumbs up. It will be good for me to understand. Okay, thank you. Okay, I'll show you something similar now, something more fun. What is this? So this one is a CT scan of the pelvis. What I showed you here was a X-ray of the pelvis. Now we are looking at a CT scan of the pelvis. So I'll just explain to you some basics of CT scan. Okay. Right. So this is the axial section of a patient's pelvis. This is the fat. Okay. This is the subcutaneous fat which is present. And if you look carefully, there is a lesion here inside. This is a mass-like lesion in the pelvis. And if you see carefully, this fat is similar to the density which is seen inside this. So from this, we can conclude that this is also fat. So this is a fat-containing lesion. But everything inside, it is not fat. This is fat. What you see here is some amount of fluid and some soft tissue. So 3 different densities are seen here. This gives rise to a very classic Pokemon ball sign. So what is specific here is we don't always see a Pokemon ball sign on CT, but we see it very frequently. Whenever you see this kind of sign, you're 100% sure that this is a teratoma. Okay. So from this side, from this particular slide, the take-home message will be Pokemon ball sign, which will be given in a teratoma. Why? Because 3 different densities will be present inside the teratoma. We already discussed why different densities are present inside the teratoma, because pluripotent stem cells fail to migrate to different sites. They stay there and they differentiate within the lesion itself. Okay. So we'll now move on to the next one. So the first one that we saw was the thumb sign. The second one we saw why 2 teeth will be present inside which lesion, and then we saw the Pokemon ball sign. Right. This one. This is a small baby. This is a neonatal X-ray abdomen. Okay, duodenal atresia. I think the slide had already pointed there once too, but okay, good. Any sign that you know of here in duodenal atresia? Double bubble sign, good. And what gives rise to the double bubble sign? Why does this appearance come? Okay, I'll tell you. So you can clearly see there are 2 bubbles here, right? There is one large bubble here and there is one smaller bubble here. So the large bubble is the stomach. Normally also in a patient or in any person, in a normal person also, stomach gas will be present, right? And then here, since there is atresia, the duodenal gas will not be able to pass down, and so there will be dilatation. Hence, the stomach gas will give rise to one appearance and the proximal duodenal gas will give rise to the second bowel dilatation, and so this kind of appearance will take place. So what you have to remember is, okay, duodenal atresia is the most common cause, or duodenal atresia is what you can write in your exam and you can get your full marks, definitely. But duodenal atresia is not the only cause of this kind of condition. Basically, anything that will lead to duodenal obstruction will lead to this kind of appearance. So duodenal atresia would be an intrinsic cause. There can also be some extrinsic causes, meaning things which are coming from outside and compressing the duodenum. Good. Annular pancreas is another important cause. Yes. So duodenal pancreas, duodenal atresia and annular pancreas are the common causes. This is clear. I think this was easy. Many of you could answer this, so it was nice. I'm happy. All right, another easy one, very easy one in fact. Please type in your answers. This is a CT scan of the spine and you're able to see something here at this level. Any sign that you have read of or anything that could draw a cloth sign? Good, 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 very good. Jail appearance, okay, jail bar appearance, right? All right. So interosseous hemangioma. So what basically happens here is, in this hemangioma, there will be thickening of some of the trabeculations, and they will be surrounded by, they will be in fact replaced by the hypertrophy of marrow fat, because of which a lot of space will look like it is empty, and the remaining trabeculations which are left, they will become hypertrophied. This gives rise to a classic jail bar appearance, also known as the Kudroy cloth appearance, which you have already answered. Polka dot is another word which is used for it when we see it in axial section. Okay, when you see a sagittal or a coronal section, you will call it jail bar appearance or Kudroy cloth appearance. And when the same thing is seen in an axial section, it is known as polka dot appearance. Okay, easy to remember. I hope people who are not answering are also getting these things. Okay. Right, so vertebral hemangioma. So till now everybody is with me. I think we are going very easy and we are going at a very simple pace. I'm trying to make it interesting for everybody, and most of them are simple. A lot of you must be knowing these things already. Okay, we'll move on. Right, this one. Come on, type in your answers. What is happening here? This is a sagittal section of the brain, and this is an MRI, Dawson finger. Okay, good. So what gives rise to Dawson finger appearance? Okay, so Dawson finger appearance because of demyelination. Basically, multiple sclerosis is the classic cause for this. And if somebody asks you to explain it, you have to say it is demyelination, which is seen in the periventricular location. And it is usually perpendicular to the surface of the ventricles. All right. So Dawson fingers due to demyelination in the periventricular regions, and it is basically plaques. These are demyelinating plaques, and it is very specific for multiple sclerosis. All right. You guys are doing good. So here's a small question for you. Dawson encephalitis. So just remember Dawson finger, Dawson encephalitis. When you're appearing for your MCQs, sometimes you might be in a hurry and you might just pick one thing for the other. So be very careful. Dawson fingers is a feature of multiple sclerosis. Dawson encephalitis is the term which is used for fatal encephalitis, which is a complication of measles. All right, so keep this in mind. These are two separate things. Excuse me. Dawson encephalitis would be a manifestation of SSVE, yes. Okay, another easy one. Go for it, guys. Sigmoid, volvulus, coffee bean. Okay, anyone else? Okay, volvulus is right, but I would not call it sigmoid volvulus. Why? Because if you look carefully, just look at the orientation. Where is the coffee bean arising from? Is it arising from the right side or the left side? It is arising from the right side, right? It is coming from the right side, and if you look at the orientation, it is going up towards the left side. Okay, so this is more likely to be cecal volvulus. Yes, right. It is cecal volvulus. So you have to also look at the orientation, coffee bean sign. Okay, that is the basic. It's good that you know about it, but you have to differentiate. Many times you don't see a kidney bean appearance in cecal volvulus and a coffee bean appearance in sigmoid volvulus. So you have to be also careful about the orientation. Okay, so this is a cecal volvulus. Not much to tell. I think cecal volvulus is a very common thing. All of you must be reading about it. Right. So we will see some named fractures. This is very important. All of you guys have to know your named fractures also for your orthopedic exams. And then again, very, very important for your pre-PG entrance exams. So what is this? Okay, which joint is this? Elbow joint, okay? It's clear to everyone, this is the elbow joint. This is very simple, it's just anatomy. What is this? This is the humerus and radius, ulna. No confusion with this, right? So, what is happening this? What is this here? Please type in your answers. Monteggia fracture, okay. Anyone else? Okay, Monteggia fracture is good, Amisha, very good, but it's an incomplete answer because Monteggia fracture in most cases is associated with a dislocation. So you have to call it Monteggia fracture with dislocation. Basically, there is fracture of the ulna along with dislocation of the proximal radioulnar joint. Okay, so it is Monteggia fracture with dislocation. So what is Monteggia fracture? It is fracture of the proximal third of ulna with dislocation of the proximal head of radius. So most of the times, in fact, more often than not, Monteggia fracture will be associated with the dislocation of the proximal radius and radioulnar joint. There is this classification. I will not go into the details, but if anyone is interested, you can read about it. It might be helpful. It might be one of your MCQs sometimes. Less likely, this is more of a radiological thing, but you can at least know that Bado classification is the one which is used for classification of Monteggia fractures. Okay. Right. Next, what is this? This is what you can call the opposite of Monteggia fracture. I mean, that is how I used to remember it in my UG days. So, not Colles. This is not Colles. Galeazzi. Good. It is Galeazzi. Yes. Yes, it is Galeazzi fracture. So, what happens in Galeazzi fracture? So, what was Monteggia fracture? Monteggia fracture was fracture of proximal ulna with dislocation of proximal radius. This is just the opposite of that. So, fracture of radius with dislocation of distal radioulnar joint. That is how you can remember, okay? Monteggia and Galeazzi are opposite to each other. Right, so Galeazzi fracture dislocation of the distal forearm. Basically here you can see diastasis of the radioulnar joint with ulnar dislocation. Okay, another simple one. I think you guys are very bright. You can manage this easily. This is a non-contrast CT scan of the head at the level of skull base. I mean, not skull base, at the level of orbits. Just look at both the orbits and see what difference can you see. No? Anyone? It's very simple, guys. Just compare the two orbits. Compare the right eye and the left eye. What's happening to the left eye here? Okay, what is this? What's the whitish thing present over here? It shouldn't be here, right? Look at the size of the right eye and look at the size of the left eye. Why is it becoming so small here? And what is the white thing happening here? Okay, I'll explain it to you since no one is answering. Right, see, this is the nasal bone. So this is how a bone is supposed to look like on CT. These are the other skull bones, right? So if you see carefully, the density of this thing which is present inside the eye and the density here, they are similar. So that concludes that this is some sort of calcification happening inside the eye, which is definitely abnormal. Another thing is, look at the size here, and this eye is completely shrunken. So basically it is shrunken left eye along with calcification inside it. So does it ring a bell? Can you think of any term to describe this? Okay, have you guys heard of thysis bulbi? I'm sure you all have heard of thysis bulbi somewhere. Okay. So what is thysis bulbi? Basically a shrunken eye which has got dystrophic calcification. There must have been some kind of infection or some injury, very commonly due to injury. Okay. Not iron deposition really, it is dystrophic calcification. So because of the injury, what happens is, it is kind of a process of healing. The eye tries to heal itself. The person obviously loses his vision here and this thing is known as isis bulbi. Okay, so shrinking of the eye with dystrophic calcifications inside. Okay, right. This is a non-contrast CT scan. All right, this is just some NCCT. It was supposed to be NCCT. So again, a non-contrast CT scan of the head. What do you see here, guys? What is the bright thing happening here? All right, we'll start with identifying the normal structures. So can you tell me what is this part that I'm pointing to? This is frontal lobe, right? This is frontal lobe of the brain. So what are these lobes here? Please type in, guys. What is this? What are these lobes here? Okay, frontal lobes here. These are temporal lobes here. Right, temporal. And this is the cerebellum here. So what is the structure left here in the center? What comes in the center? Brainstem. This is the brainstem, all right. So you can see some abnormal hyperdensity in the brainstem. And now what if I tell you that the patient is hypertensive? Okay, one of you have already answered, good. Pontine hemorrhage, yes, it is pontine hemorrhage. Most common cause being hypertension. Okay, hypertensive patients, in chronic uncontrolled hypertensive patients, pontine bleeds are common. We see it very commonly in our practice. Okay, so now the question is, what they will ask you in exams is, what is the most common site of hypertensive hemorrhage in brain? Can someone answer this question? What is the most common site of hypertensive hemorrhage in brain? Putamen, good, very good. Putamen, okay, okay. So what is the second most common site then? Thalamus, okay, nice. Okay, good. So putamen is basically a part of the basal ganglia itself. So basal ganglia, you can be more specific and call it putamen, followed by thalamus, then cerebral hemispheres, then brainstem, and then cerebellum. So this is the sequence in which the hypertensive hemorrhages happen. Most commonly in our practice, we see basal ganglia, thalamus, and yes, pontine hemorrhages are also very common. But most of the times, thalamic hemorrhages directly, they go and extend into the cerebral hemispheres because they are usually very large hemorrhages. What other causes of hemorrhages do you know of other than hypertensive hemorrhage and trauma? So if I say this is not hypertensive hemorrhage and this is not even trauma, what other things will you think of? No? So the causes of bleed in the brain will be divided into traumatic causes and non-traumatic causes. Okay, good. Aneurysm, aneurysmal bleed, again very common. Aneurysms and AV malformations, arteriovenous malformations, right? And which is the most common aneurysm in the brain to bleed? Berry aneurysm. And what is berry aneurysm? AIIMS aneurysms, good. Any associations that you know? Anything associated with berry aneurysm? Any other systemic condition that is associated with berry aneurysm? Any systemic disease in which the patient can also have? Okay, good. Ehlers-Danlos is one, Marfan's is another. And another common one that you have to remember is, yes, Marfan's, good. And other associations are Marfan's and all these conditions. No, they also have, the patients will also have coarctation of aorta very commonly. So when you see a patient with coarctation of aorta, and if you have the head images provided, you always try to screen those things and you try to find out a connection between the two. So when you see a berry aneurysm in the young, and you also know that the history is of Marfan syndrome, Ehlers-Danlos we don't commonly see, but yes, Marfan's we do see once in a while. Very often you will see patients who have coarctation of aorta and they present with bleed in the brain, and in those patients we see AIIMS aneurysms. Okay, so commonly associated with coarctation of aorta, and coarctation of aorta in turn will be a part of one of these syndromes very commonly. All right. Okay. What is this here? Shoulder and upper humerus are being shown to you. What can you see here? Can you see something? Can you see something abnormal, something expansile here in the humerus? And can you see a fracture line? Okay, SBC, simple bone cyst. And your answer is incomplete. What else would you say? SBC with pathological fracture. Yes, you have to write that. Okay, if you just write SBC, you get only half marks. You have to write if there is a pathological fracture, that needs to be mentioned. All right. So why is it SBC and why not anything else? What made you call it SBC? So what if I call it ABC? What if I say, no, this is not SBC, this is aneurysmal bone cyst? How will you defend it? And okay, metaphyseal, unilocular. Good. Centric, yes, that is very important. Symmetrical distribution, that is not symmetrical exactly, I mean even distribution. It will be causing symmetrical expansion of the bone. Had it been ABC, it would be eccentric. It would be more swollen on one side and less swollen on the other side. Whereas SBC, it will have a more uniform expansion of the bone as seen in this case. And then there is associated pathological fracture. Any sign that you know of? Sign that will tell you about pathological fracture in SBC? Fallen leaf or fallen fragment sign, very good. Fallen fragment sign is what we were looking for. So it is very commonly seen. Whenever, like SBC itself is not a very common tumor, but most of the times patient will present with a fracture because since it is a benign tumor and the patient most of the times does not have any complaints unless he has a trivial trauma and then he develops fracture. So most of the times patients will present with fracture. So most cases with SBC that we see practically will have fracture because that is why the patient presents to you. All right. So fallen fragment sign in simple bone cyst, which is also known as any other name for simple bone cyst? Okay, it is also known as UBC, unilocular bone cyst. So if in, yes, unicameral or unilocular bone cyst, right? Okay, what's happening here? Plain radiograph of the wrist has been given to you and you also have the history here. You know that the patient had wrist trauma. So, again, I want the name of the fracture here, please. Colles, no, this is not Colles. What else? So what are the named fractures of the distal radius? That is very important to know. You have to know all the named fractures of the distal radius. You have to know which one of them involves what. Barton's, okay, close differential, but not correct. So, okay, I'll tell you. This is the radius. This projected part of the radius, Schoffer's. Schoffer's is the correct answer, good. Schoffer's fracture, also known as Hutchison's fracture, okay? The other name is Hutchison's fracture. So this basically is the radial styloid, and if you see carefully, the fracture is going through the radial styloid. Basically, the radial styloid is getting separated from rest of the radius. So fracture of the radial styloid, and you have to trace the line of the fracture carefully and see that it is extending up to the articular surface. So extension up to the articular surface is very important for the diagnosis to be made because Colles fracture will not involve the articular surface. Please remember this point. Colles fracture and Smith's fracture, these two will never involve the articular surface. If the articular surface is involved, you have two differentials, Schoffer's fracture and Barton's fracture. Now, how do you differentiate whether this is Schoffer's fracture or Barton's fracture? If the fracture line is going through the radial styloid, you call it Schoffer's fracture. And if it is not going through the radial styloid, it is going through any other part. Supposing it is going through here or here, Then the word that we use is Barton's fracture. So Coley's, Smith's, Barter, and Schoffer. These four fractures, you should not have any confusion. Okay. If you are confused with it, please go back after this class, read about it, and make it very, very clear in your mind. Okay. Because these four things will be asked to you frequently in exams, in various exams. So you have to know the difference between these four fractures. And most often, only these four will be given to you as options in your MCQs. So in those cases, you have to have those minor differences very clear. Only then you can answer correctly. All right? Okay. So Hutchison's fracture of radial styloid, also known as Schoffer's fracture. So you can just make a note of this diagram. Coley's fracture, it will have dorsal dislocation, Smith fracture, volar dislocation. Again, Barton fractures. So Barton fracture again will be dorsal Barton fracture and volar Barton fracture. These are the ones which have been given to you. And this is the radial styloid. If the fracture had been crossing through this part, we would have called it Schoffer's fracture or sorry, or Hutchison's fracture. Okay, you can take a look at this radiograph now. This is a cervical spine lateral radiograph. Try to start counting the cervical vertebrae from the top to the bottom and try to see if you can detect any abnormality here. Beaking vertebra. No, this is normal. This is not beaking vertebra. Okay, are you guys able to count? What is this? Which vertebra is this? This long one here? Is it C1 or is it C2? Okay, this is C2, okay? And this is burst fracture. Where was the burst fracture here? Let's look at the C7. Look at how this is C2, this is C3. Look at how rectangular this is. Look at how rectangular this is, this. And then suddenly when we come here, there is something not right at the upper margin here, right? It is compressed. So if you compare the vertebral height of this one, so if I measure this, I may get something around maybe 1.5 centimeters. And if I measure this, I'll get something around maybe 1 centimeter or even less. So this is basically burst fracture. What has happened is there has been a fracture that has led to compression, and along with the compression, some bony chips have been flying around. Just a second, my mouse is okay. Can you see this bony fragment which has come out in this area? So burst fracture is most of the times due to a very, what do you call it? A very high impact fracture on the spine that will lead to complete compression, a lot of compression and wedging. So this is comminuted fracture with compression and wedging of the vertebral body. Okay, just remember this is vertebral body. Hangman's fracture, no. Why would you? Okay, I think you were talking about this one. This is completely normal, okay? Hangman's fracture, this is not hangman's fracture. Maybe next time if I get a chance to take a case for you guys, I'll show you what hangman's fracture is. I was just trying to make you guys identify the normal vertebral bodies. So C2 is the one which is the largest, all right? This posterior element that you see, this is the posterior element of C1. That is because this is the atlantoaxial joint. So C2 will go and it will form a joint with the C1 here. So this is the atlantoaxial joint. And as you all said, this is the axis or C2, C3, C4, C5, 6, and 7. So C7 over here has a burst fracture, which is a comminuted fracture with compression and wedging. All right. And if you look carefully, there is one more fracture here. Can you see a bony chip here posteriorly? Where has this come from? This has come from the posterior element of C6. So this is a burst fracture, and this is also a, what is the name of this fracture? What do you call the fracture of spinous process that takes place? Traumatic fracture of spinous process. Ever heard of Clay-Chauvelur's fracture? If not, please go back and read about Clay-Chauvelur's fracture also. C-L-A-Y, Clay. Okay, Clay-Chauvelur's fracture. So mainly I had shown you to tell you what burst fracture looks like. Okay, burst fracture is comminuted, compressed, wedged fracture of the vertebral body. I'm here emphasizing on the vertebral body because most of the times posterior element will not be involved in burst fracture. If the posterior element is also involved with the anterior element, then the name given to it is chance fracture. So please remember, burst fracture, chance fracture. Both of them are a little bit different from each other. You have to know it. Okay, I think too many fractures for you guys for today, but these are all really important. So I tried to cover at least some of the related topics so that you can go back and read in detail. And not just for radiology, they are actually important for your other subjects. So you can actually go back and read them from your different textbooks of radiology, which radiology or orthopedics or whatever, medicine, surgery, all your books. Okay, very easy, very, very easy. I will tell you what this study is. So this is basically a lateral X-ray. If you see carefully, you can see vertebral bodies here. And then there is this structure anterior to the vertebral bodies, and this is the chest. So what will come here? This is a barium swallow study. If I tell you this is a barium swallow study, what is this structure then? Corkscrew esophagus, very good. Yes, it is corkscrew esophagus. Okay, very classic. So corkscrew esophagus, basically smooth muscle segment is mainly involved. So if I tell you smooth muscle segment is involved, which part of the esophagus am I referring to? Which part of the esophagus has striated muscles and which part of the esophagus has smooth muscles? Anyone? Anatomy? Okay, it is the lower part of esophagus which has smooth muscles. Yes, distal part has smooth and upper part has striated. Very, very important to remember. Why? Because when you read general surgery and when you read about CA esophagus, you have to know these things because that will decide which part of the esophagus has adenocarcinoma and which part of esophagus has squamous cell carcinoma. Therefore, this part of anatomy is very important to know. Okay, so corkscrew esophagus, not going into the details. Basically, there are some non-peristaltic contractions that are taking place in the esophagus. And since there are multiple contractions which are not going through, it gives rise to a corkscrew-like appearance. Okay, just one last one to go. Yeah, very simple again. What is happening here? What is wrong with the vertebral bodies? Rugged jersey. Okay. What is the cause of rugged jersey? Come on, quick. Hyperparathyroidism. Okay, does anyone want to be a little more specific here? Renal osteodystrophy, all right, very good. So renal osteodystrophy is what leads to secondary hyperparathyroidism. And this kind of appearance, the rugged jersey appearance that you see, that is very classic for secondary hyperparathyroidism. So mostly primary hyperparathyroidism, we don't see this kind of appearance, but secondary hyperparathyroidism due to renal osteodystrophy is what gives rise to this kind of appearance. Okay, so rugged jersey spine seen in secondary hyperparathyroidism due to renal osteodystrophy. Okay. All right, so I think we are done for the day. I hope it was a simple session for all of you to understand. I tried to make it a little enjoyable for everyone. I selected cases which are simple and which will also be useful to all of you. So what was the first case that we studied today? What was the first case that we studied today? What was thumb printing appearance? Ischemic colitis. Okay. And then we also read something about a Pokemon. What was Pokemon ball sign? Very nice. Okay. All these fractures you have to be very familiar with. All right. So I think we'll end the session. All right. Thank you. So did you all guys enjoy the class? Okay. All right. All right. Thank you. I'll log out now.